I'm indeed here in Verily, and I'll say a few words about Verily just to explain the setup and the relationship to Google. And I wanted to take you today through a journey. And as Freddie said, I'm leading Verily site in Israel. So I'll say a few words about value-based care and why we think that this is important. Then I will say a few words about Verily and what is Verily, and then switch to medical imaging, our domain, and say a few words about the connection to project that we are running in Israel between medical imaging and value-based care. And then, as they say, now we can eat. That's the end. So I'll start. This is an American company, and I'll speak a little bit about the U.S. healthcare system, but I think that is reflected in many healthcare systems over the world. And I'll try to present a conundrum. I think that the U.S. leads medical innovation. Everybody, when they need something very personal and very urgent, a lot of times they go to the U.S. for a solution. I saw the system works for individual in a very impressive way. Not talking about robotics and surgery and this is questionable maybe, but the vaccination and for COVID, etc. And maybe this is related in a way to the large expense that they put in healthcare. So healthcare is about 4.1 trillion, about dollars a year, or about 12K per person, and this is a lot, and this is about almost 20% of the US economy, which is much larger than most of the countries in the OECD. And that probably led to part of this innovation, but beside it, there are a couple of issues that worth mention. While doing this magic and doing organ transplant for 35K people, there were a couple of misses of about 50K people that use opioids and just deceased, and about 50K that committed suicide, and issues with about 50% of the adults with blood pressure that leads to many cardiac issues and dementia and whatnot. A lot of people are not insured. 10% have no insurance, and close to half of the population is underinsured. And worse than that, if you look at the life expectancy in the US versus the world, as you invest more and more, and this is part of the conundrum. A child that is born these days, this is for 2015 without COVID, but I think it's still around these numbers. We live about 5 years less than a similar child that is born in Japan, in Israel, and maybe even in Romania. So I think that is certainly something to think about, and the question is, so I think we agreed on the first from the Four Novel Truths. There is dukkha, and the question here is what is the reason? A couple of the reasons, and I think there are, I mentioned here a lot, but I think that some of them we are focused on those, and some probably are of interest to everybody, because it's in many other systems, as I mentioned. First, there is a lot of waste there, about 1 trillion from the 4 trillion just going to fraud and abuse and failure to care properly. There is overtreat, overdiagnosis and overtreatment, as we mentioned. Deadly mistakes. This will be the one of the main topics that I'll speak about. Some of the reason, I think you already heard some from Professor Sabo when he mentioned issues in pathology, and Professor Kimmel that mentioned similar issues, and I'll mention some more, but it's Medical errors, the third leading cause of death in the US. I hope you understand that. I mean, it's an impressive number. Some more reasons. Inconsistency. Practice medicine inconsistently. When we are not fully informed. It's a variation on the mistakes, but this is something that is systematic. Bureaucracy. Tons of time from pros that is invested in administrative tasks. OECD, 3% here, double in the US. Pushing unnecessary and expensive treatment that I think anybody that was in the US and tried to use the system got that. I mean, all the issues of go take this exam and that scan, etc., etc. And the other two interesting causes for these issues is waiting. And this is part of the effect of being uninsured. And then when you get the patient, this is sometimes too late or it will be very expensive to treat. And the inability to create behavior change. This is also something that I'll talk about, but this is critical. People don't take it too seriously, but this is a serious issue. So this is a couple of the causes. So this is the second one. I mean, the reason for the pain, and certainly there is an addiction here, and this is part of the overtreatment and the system that is geared, and this is part of the incentive. The incentives actually set your system. That happens, I think, all over the place. We could talk about many issues that we see in Israel due to wrong incentive systems of incentives. And here, certainly, there is an addiction. And what could be a possible cure to that? This is a story that I heard in my family a long time ago when I was a child about some magics that happen in China. There is a Guangzhou or another small Chinese doctor that get paid a reasonable amount of money every month as long as everybody are healthy. But if, ladies and gentlemen, if a small Chinese is getting a running nose or something like that, then he's paid less, etc., etc. I found a couple of Chinese doctors that called Guangdong, and there. Maybe I'm there. Okay, excellent. And when there was a survey from many people on the on what could be the one and most important thing to change in the US to move the system was paying for health, and that I think indeed is part of the incentive and the way to possibly go. This is actually the value-based care, the payment for health. So what you do is providers, hospitals, physicians are paid based on patient health and outcome. This, I think, sounds very logical, but it's not practice. I mean, it started to be practiced in some places in the US. I think that Medicare Advantage has about 25% of the adults under value-based care, and it's going in, but it's not still not the major way of practicing medicine. Providers rewarded for helping patients improve their health and reduce effect and incidence of chronic disease. This is contrary to what is paying for action or fee for service, where providers are paid based on the amount of healthcare services that they deliver. And in this case, you just have tons of action, and not necessary, as we mentioned. There was a very nice book that I read from Vivian Lee, who was the head of the University of Utah Healthcare. This is about 4 hospitals and another net of 18 hospitals, about 20,000 employees, taking care of a big chunk of Utah and a couple of other states nearby. She went with the hospitals through a value-based care revolution that was pushed from the outside, starting to go into a couple of places in her system. And when she started to practice in that way, And because she was also the dean of the School of Medicine, as it's the University of Utah, then after 6 years, there was the 7th dangerous year, the sabbatical, Kimmel sabbatical. And when there is a sabbatical, then many interesting things happen. So she went to go into different places and see how they practice value-based care and to see other systems in the US. And eventually she got to Verily, met the CEO, Andy Conrad, who suggested her to try and do a massive change. One of the things that she thought that data and massive use of data and machine learning on that could be a catalyst for changing health. And he convinced her to come. And from that point, she started working in Verily, and I'll mention her project as an example. In The Long Fix, I think it's a very nice and easy to read book, and she tries going through the American system, but I think it's general truth, to present some ways on how to practice value-based care and how it will look like for patients and for the delivery system and for the different players, I mean providers, including the pharmaceutical industry, etc., payers, etc., etc. And it's a recommended read. And as she's in Verily, I'll try to say a few words about Verily, and maybe you could get some hints why she came, and then I'll describe one of her projects, which will give you, I think, a feeling of how you could practice value-based care in an effective way. And this is one of the successful projects in Verily. And then I'll talk about what we are doing in a similar context. Verily. Verily is a sister company to Google, so it's an Alphabet company. I think that Alphabet has more shares in Verily than in Google, but everybody are focused on Google. I don't know why. There is Waymo, the car company. There is Wing. There is Nest and a couple of other companies. And there is Verily. I think Verily was the first bet going from Alphabet. And there is a lot of synergy on working and cross proliferation between Google and Verily. And it happens a lot that we are discussing, working with people in Google Research or Cloud or YouTube, etc., etc. Verily started from Google X, and that's part of the DNA. All the life science projects that were in Google X moved to Verily, and then we got tons of projects in Verily that started to converge in some way. Today, Verily, a precision health company, includes between 1,500, 1,600 employees, a couple of solutions. Solutions are a lot of times joint ventures like the Galvani, which is a neuromodulation effort with GSK, or the Verb project, which built a robot that actually was, the plan was to match the Da Vinci and eventually Johnson & Johnson, both, etc. So there are 46 like that, many patents, etc., etc. And the idea is to use this mix of data and technology and clinical expertise and bring the promise of precision health to everyone every day. It's good words, and I'll try to just show an example because otherwise it doesn't mean a lot. 4 lines of business. There is the devices, medical devices, building medical devices like the robots. Life science, which are doing different projects. I'll give just an example soon. The clinical study platform, opportunity to run very effectively clinical trials, and the health platform, Verily Health Platform. This is led by Vivian Lee, and I give some examples on what they are doing there. Some examples of projects that are done, immune profiler, just trying to help drug discovery by finding a path to new targets. validate them, digital pathology, similar to what Professor Kimmel showed, virtual staining for different purposes, primary clarifier, certainly things to clarify there, wastewater epidemiology, similar to, I think, what we did in Israel. I think in the Technion there was a project that tried to find COVID instances in the sewage, and there they are checking variants and working with wastewater and see what you could say by that, and debug, which are trying to use sterile insect technology, trying to create mosquitoes that will help by eliminating other mosquitoes from trying to cure Zika and other disease like that. So I think that the interesting thing is to see how to use not just these specific projects, but to see how you could really make a change in trying to move and do the precision health that Professor Sabo mentioned close to the end of his talk, going in steps from the traditional healthcare that advocates one-size-fits-all treatment to going into the precision medicine, but pushing it further from working against a group and then working mainly in genetics and trying to take that into the next step of precision health, working one-on-one and trying to use all the data that you could bring in. And in that way, trying to use whatever in Verily, whatever we have, I mean, all the different, and if needed, we will develop. I mean, and for example, I mean, in medical devices, they developed a watch that will help to do more precise clinical studies. Glucose monitoring device was invented there, et cetera, for working and delivering precision health. So let me just go briefly over a couple of projects that are done in Verily Health Platform and then focus on one of them, which I think is cool. There is Onduo that is treating chronic diseases in using mainly virtual care. Healthy at Work that mainly helping employees treat the local conditions of their employee, mainly COVID-related and expanded later on. 115, issues of addiction, mainly opioids and the way that you could treat them. Issues related to sleep under Primasen, and Granular, an insurance company that tried to help insurance company to insure their employees. So I want to focus on Onduo and show how possibly one could do and treat chronic conditions in a remote way and try to succeed with that and doing it under value-based philosophy. I think that the main thing, especially if you look at this slide and understand that direct healthcare is responsible for only 10% of the outcomes. So what is the 60 other percent are coming from individual behaviors, which is crucial, and social factors. And the question, I mean, can you use this red part and influence the other parts? And this is part of the game that Verily is trying to do. So the idea is to look at the patient and try to support between provider visits and give personal care. The idea is very simple, and I think the main thing is the execution and use some type of, I'm not sure if it's basic technology, but technology that currently is really available. So what you do here is going, instead of the one-size-fits-all, you're going to customization to the individual needs. You go to, instead of condition by condition, you do multi-condition. This is data. Instead of episodic nursing outreach, you do continuous monitoring, et cetera, et cetera. I'll go a little bit quickly to go to the fun part that I want to be able to cover also the medical imaging. But I just want to give some taste of the approach. Let's look, for example, on the personal path of a patient. And let's say that the patient has some conditions that includes, for example, hypertension and A1C, relatively high. Then you start with monitoring, and you try to using some type of remote monitoring using the phone, of course, and some communication with the patient, try to monitor the A1C. If you see that this doesn't work, then you go and add some, and it's not a linear path. Then you add glucose monitoring into the path. Adding that, usually you get some improvement, and then, for example, you get in some issue of stress, then you add for that another type of monitoring, in this case, blood pressure, and then if needed, you change medication by virtual care. What you see here is a couple of ingredients that are coming as needed during continuous monitoring. You have the base of the pyramid, the low needs, and this is usually doing through continuous monitoring on the phone with data and machine learning. Then if needed, you bring in the coach, and of course there you could add a couple of devices that could give you better ability to monitor what's going on. And at that point, if needed, then you bring in the clinical help, and you change you could change medicine and things like that. Just as an example for a member story, you see someone with 12.2 A1C, which I think is clearly type 2 diabetic. You see the BMI and the weight, no medication, and then there is a start of working in a personalized program, going close and adding as needed the use of CGM, the continuous glucose monitoring. And eventually with that, and I think the use of a coach is critical here, the personal touch, I mean, it's remote, but I think it's still critical. She was brought into 6.2 A1C, which is, and going from 12.2, I mean, into a pre-diabetic situation, I think it's impressive. And there are many stories like that, and I think part of it, it's the personal monitoring and the coach that is coming in. This is critical. And the ability to do monitoring on all the conditions and to see that you could indeed do a real change. You could see here the amount of going down with the A1C according to the starting condition. And I think it's impressive. I mean, taking eventually 3.3 from people that started above 9. I won't go deep into that for the interest of time, but I think that the ability to do this change using these components, I mean, the digital intervention, the smart devices, and the telemedicine, brings eventually, and you see on the right, the different components, give you ability to eventually bring results. Eventually, the Onduo team expanded into different chronic conditions, including cardiac, including hypertension, including issues related to mental health, depression, and all that. I think they are interrelated in many ways, and I think that this is impressive results eventually, and I'm a great believer in Onduo. Some of the riddles there include understanding the effectiveness of mental treatment between visits just by discussing virtually with patients and using monitoring via the phone, and the results, I think, are interesting. Now let me go into into diagnostics, our field, and we could. I'll answer later questions on this part of the talk. So AI is great. Now let's talk a little bit about diagnostics. I'll talk about two fields, one diagnostic in GI colonoscopy and the other on surgical. I think about the need you heard, and we could add here what's going on in CRC. The fact that medical errors are number 3 I think it's something that should be changed. In Israel also, I think that we have impressive number there, and I think it's all over the world. Radiology we could speak about. In GI, I'm looking at the rate in which polyps are missed in colonoscopy. Polyps are the main reason, 90-something% for all colon cancer. Colon cancer, the things that hurts is, beside the fact that it's the second deadliest cancer in the US and the impressive number in the world, that eventually it's preventable. And it's preventable if we'll catch these polyps on time. And there are not many cancers, I think, that give you a warning. And this one, I mean, is silent, but if you do this inspection, then it's preventable. And the question, I mean, how could we improve the situation there? You could do with the patient. First, there is a behavior change, and you need to go now still to colonoscopy. And the other is the GIs. And the GIs tend to miss, and why they tend to miss, there are a couple of reasons on the missing. Missing is about 20 to 40%. In some procedures, from some places, you see even higher percent. The three misses, I mean, you have misdetection, and you have miscoverage, and you have misclassification. Misdetection is just the situation where the polyp is in the field of view and you miss it. The other thing that's very hard to see what's going on here, if I won't turn my sight to the left, no need to watch there, but the polyp is there actually. But okay, we surrender. So the question, I mean, could we help make sure that there will be a full coverage of the colon? And the classification is also an issue. There are the things and the way to go on resect and discard. Can you do that? Can you save pathology and help Professor Sabo being more with his family and not doing slides during the night? Polyp detection, I think it's, we build our own polyp detection. This is a relatively straightforward technique. I won't go too deep into the deep nets, but part of it is the data. If you have clean data, I think that Professor Kimmel mentioned that, and if you have enough data, you don't need, I mean, at some point the added value is diminishes, but here I think with about 5,000 videos, we got good results. You need to pick the right tool if you want to be a good carpenter. And here, eventually, we locked on variation on the retina net. And then if you add another component, a temporal component, you get good performance. You could see here the performance of the net that we got. You could get into a very good percentage. I'll mention, you could see here the competition, which is, I mean, in detection, I think we are there already. So you see field closing on this number. It's always nice to be the first. You will not be able to maintain it for life. You could fight for that. But I think the technology is there, and people can do that. The interesting thing, and we publish a paper on that, is the elusive polyps. Can you catch those? And the elusive polyps, we talked about two types of elusive polyps. One that is just being in the field of view for a very short time and disappeared, which means it was there, but you didn't see that. And you could see that if you want to give under 5 seconds, then the sensitivity of the artificial-based system is 88%, but the endoscopist has 31. But if you go into less than a second, then there is no chance. The system still keeps performance, and the endoscopist loses there. Now, if you want, you could, you saw the polyp? Okay. Okay, I got it. It's hard to see because of the screen there, but there is a polyp there. I can show another case. I think the chances of catching when you are running forward, very slim. All the issues of behavior during procedure and what you could say about the skill and the way that the physician behaves is very important. And here, the other things, I mean, I saw it when I saw surveillance system long time ago in a couple of security-related applications. You see the ability of a good system work against the human, and there is no chance to win. And if you have this tool, why not use it? The second type of elusive polyp, I mean, one that disappears quickly. The second one, and this is always cool to see, is a subtail polyp. Those polyps, I mean, we took 200 videos. We have a feeling that, we had a feeling that something is wrong there. We wanted to check. We took 200 videos, look at all the false alarm, and then gave them again to a couple of endoscopists. And apparently about 40 of those were polyps that they admitted to be real polyps. Some of them worth a second look, and other clearly a polyp that need to be resected. So interesting to note. We did a couple of clinical trials. This one is in Jerusalem, Sharet. We got impressive results there. That was during COVID, and I think performance was great. On the average, we found and brought in additional 1 polyp per procedure. Other issues there. This is about detection. As I mentioned, detection is already there. That's my opinion. Classification is getting there. There is an importance to help and give some confidence to the GI. Currently, it's only a binary classification. The systems cannot do better than that. I think it's issue of data. So currently, it's just hyperplastic and something else, adenomatous or cancerous. But there is a good stable progress there, and again, data. And on the missing polyps, I'll just mention the issues that are related to navigation and what you could do there, just out of curiosity. One of the things is to find where you are. According to the European Union, you need to mark areas that you cross and to make sure that you got eventually into the end, which is important. It not happens always. And just take pictures along the way. Can we do it automatically? The GIs not always know where they are. I'll show other things that they don't know exactly what's going on. I'm just mentioning the ability of using technology that is around. It's public, but we could use it being close to Google in a way, and if you want to discuss the developers there. Using motion and ego motion, the question and navigation and the ability to reconstruct. Could we do this full coverage? The idea of full coverage is coming in and trying to say eventually what part of the colon was covered, like the red ones are covered and the blue ones are not. So can we get into that situation? What fraction of the colon is covered? This is a cool riddle, and it's geometry, so I'm sure that many papers could be published on that. Many papers. Just checking who is asleep. Food will be served soon. If you look at it, and we could argue about the definition of the problem, but we are trying to find what part of the colon is covered. If you look at a certain trajectory going on the center in the lumen and trying to see all the points that you could see during your trip, that will be the full set of visible points on the colon. And then what we are trying during track on the right, all dots that It reminds me, there is a story about a screen in Romania about dots that were seen during the visit. And the question, I mean, could we teach the system to find what fraction of the colon the GI saw while walking there? I'll do a quick round. This is part of an example of using technology that is around and coming in this case from Waymo, unsupervised 3D. What you need to remember here is that you have no ground truth. So on one hand, it's great because I can tell you anything and you should believe me in a way. On the other hand, it's very hard to teach systems like that because you don't have ground truth. How could you teach a system like that? First, to reconstruct, we could do it in unsupervised manner. So we built on one picture-based 3D extraction. And then you could see the result here. On the left, you see an RGB image, and then you could see the ground truth, and then you could see the predicted depth. And this is this a real colon? Is this reality? There is a song like that. Right. Why won't bring? We should use simulation. I mean, digital twins. And you could see what you get learning on a simulator and from an Israeli company called 3D Vision, 3D Systems. That we got the data from them and then trained on those. And you could see the depth from real video. At that point, I mean, you could see also the connection into a couple of other real images and the depth. And then we went into training and went to coverage. I think the interesting thing here is to do a two-phase approach and get pose on one hand, using the approach that I mentioned from Waymo and getting pose and depth in one shot. And the second is to do coverage, and for that there is the use in synthetic data and eventually doing domain transfer. I could expand on that. There are a couple of fun parts in the nets, or maybe after we will go to a break. The interesting thing that I wanted to mention is the relationship between the system performance and the GIs. If you ask GI what part of the colon is covered in this picture, certainly in this segment, it's very hard for them. And you could see here and here you have the ground truth, so you can compare. You see the GIs on the right, ground truth versus between the algorithm and the MDs, and you could see that they are all over the place, and the system is doing about 2.5 times better. There is the issue that we mentioned about trying to match what the GIs think. And comparing to this scenario, I mean, we are getting a very good score. But this is part of the issue when you don't have ground truth and you still need to find a way to teach the system. There are interesting things here that I could mention about the way that we train the system. Again, we could do it after the break. I think the interesting thing to think about is what else is needed. I think that coverage could be done, but there are a lot of better ways to approach it, and there is still a lot of research that could be done there. Other things that we could use when we are going into colonoscopy and trying to do that is using different type of modalities. It's not done currently. Help in decision making, taking the patient metadata. And try to do adaptive performance relative to the patient. The other things that we could help with the GI with is skill assessment and improvement, decision making that is needed in a lot of times, even in colonoscopy, which is a simple case of surgery that I will try to say a word about it. And automatic reporting is important. I mean, it's not rocket science, and it's not. It will save mainly time, but time is precious. The last thing to mention is thinking about this type of changing GI. GI, I'm talking mainly about colonoscopy. IBD is a huge area of research and region to work and think about. But if you think about disruptive technology, you could close your eyes and say self-driving cars or e-commerce, telephony at the time, and then AI in GI, and is it really a disruptive technology, and how it could look like if we do all that. The last thing that I want to mention, and I don't have a lot of time to talk about this one, but is our work on surgery. You have very similar issues there. The world is more complex, but it's fun what you could do with AI there. I assume that everybody knows what is laparoscopy and minimal invasive surgery. There are issues with surgery, very similar to, this is the motivation, and there are a lot of lap cholis. This is why we went on gallbladder resection. And if you look at the different stages of the surgery, when you have the trocar insertion, the preparation, by the way, it's, when you start looking at surgeries, it's a world. I mean, it's very similar to what you see when you look at an animal, and getting the right understanding. It's not like what you see in the books. Then after preparation, you go into the calo dissection, clipping and cutting, and then you do dissection of the gallbladder packaging, cleaning, coagulation, and extraction. Which is the most important part? Freddie, you should know. Exactly not. It's good not to leave anything behind. This is another thing that we could arrange. But the thing, I mean, you might think that clipping and cutting is the most important thing. Certainly it is. But what you need is to be careful before you cut, because after you cut, you're in a different game. And this is the calo triangle dissection. And for example, here we got into ability where we could recognize a critical view of safety. I won't go into the net. This is, first of all, you need to find this area where you just look at the structures and you recognize them. And then you are going to help the surgeon to approve that what you are going to cut is the right place, which is a challenge. So you need first to find the different phases. That was done. And after that, I mean, we could do it also in complicated cases where we have bleeding. By the way, each surgeon, when they are getting professional, they have their own style and the way to cut, and they change phases and things like that. You need to work with them. The issue is to recognize this triangle and make sure that you find the structure. The structure here, you have the cystic duct, you have the artery, the cystic artery. These two structures, you have this thing, which is the common bile duct. And if you touch it, then it's not good. And the issue, I mean, and this is the clear difference between this structure and there are issues. I mean, they are not so common, and we could talk about issues that are related to bile duct injury and the rates, etc. But it's not this drawing. I mean, the clear drawing, and you could see here, everything is clean. But if I'll show you, what we tried is to make sure that you see, and here it's relatively clean. It's not easy to recognize the structure. Can you throw in your mind the clean structure that you saw in your book 3 slides ago and project it here and say, where are you going to cut? And these are, I mean, this is part of the plumbing. I mean, you could see here 1, you could see here 2, and then are you going on the right one? I mean, is this the cystic duct? Or maybe if it's the common bile duct, then you're not in a great scenario. What we did here, we just mentioned to the surgeon in the green where he got 50. And another approach, we did also clinical trials, also in Jerusalem, Shaare Tzedek, up to now very good results. And you could see here, we talked about 4 conditions that need to be fulfilled in order to you. And we also do segmentation. You could see the area, the triangle that needs to be cleaned between the 2 vessels, the cystic duct and the artery duct. And you could see the conditions on the left and when you are in a critical view of safety. And this is one of the ability that we have with this machinery to show that we could help during surgery as well. We could talk about results, but I think that I'm behind on time. What I wanted just to mention in a few words, the journey that we did in the last hour. I talked first about value-based care. I know that it doesn't look like value-based care, but this is one of the pillars. I mean, diagnostics, misdiagnostics, into eventually getting into the 3rd leading cause to death, medical errors. We talked about one approach to do value-based care. It seems simple, but it's not activated. To change something, I mean, can you do, and you will get paid if you take this patient and lower the blood pressure to X, or you change the AC1 into whatever, 5% or something like that. So this is, I think, an important direction. Said a few words about Verily and the Verily Health Platform and this approach, which could go into different clinical. There are other work that is done in Verily. And then the diagnostics in colonoscopy and in surgery, and I think that there is a long way to go. This is just one of the first in a journey, and that's why I'm having fun. Besides these parts and other fun things that we are doing, we have, if somebody wants to do a fly in the colon, I mean, we can arrange it. We have the technology.